Hi, good evening, everyone. Thank you so much for joining. We are rerunning our second session of Community of Practice Child Mental Health today. We had this session at the start of the month, but unfortunately, quite a lot of people couldn't really get the link, so we are just repeating the session. Thank you so much. So let's start. All right, so our second session for today is on aggressive and challenging behaviors. I would like to formally start the session by acknowledgement of the country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place. The Wurundjeri Woi-wurrung people, the Boon-wurrung people, and Wadawurrung people. We pay respects to elder past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Community of Practice aims to improve collaboration between practitioners working with children and adolescents in various capacities. Our guidelines: we agree to stay on mute unless speaking, raise your hand to speak, keep conversations confidential, if possible, keep camera on, introduce yourself and your role when speaking, share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests. Ask questions. No question is silly. Some housekeeping rules during the education component. Please ask questions via chat box. The session is being recorded. Please ensure you join the session using the name you registered with so we can mark your attendance. Certificates and CPD will not be issued if we cannot confirm your attendance. How to change your name in Zoom meetings. Click on participants depending upon which medium you're using. If you're using an app, click on your name. If you're using desktop, hover over your name and click the three dots. With Mac, hover over your name and click More. Click on Rename, enter the name you're registered with, and click Done, Change, or Rename, and you're all good to go. Our psychiatrist, Dr. Prakash, he's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. He will be presenting our educational component for today. And a bit about myself. I'm a GP who works at Gunawara Medical Center and Respiratory Clinic, and my areas of interest are child and adolescent mental health and chronic disease management. So I would like to invite Dr. Prakash to present the educational component for today's session. Thank you, Dr. Prakash.
So one of the common problems that drives aggression in children is the temperamental vulnerability to overactivity and irritability, which is seen in infancy, which then manifests as an argumentative and defiant preschooler or the early child in the sort of early years of primary school. And then it progresses to physical aggression and more antisocial behavior, conduct disorder behavior like stealing and gang-related aggression or aggression as a loner. And then that results in sort of antisocial behavior of the adolescence and adulthood. But it is possible to turn the trajectory away from that at each stage. So that is something that we have to keep in mind. Lots of children with childhood conduct disorder had earlier oppositional defiant disorder, but most of those who have oppositional defiant disorder do not actually develop conduct disorder. So it's possible to change the trajectory. And only about 10% children with ODD eventually develop antisocial personality disorder, which also means that the other 90% are able to be turned away from that trajectory. One of the things that we have to do, and we do in mental health, is sort of do a comprehensive assessment of the children with respect to their antisocial behavior and conduct behaviors. And that includes, checking their physical health and also trying to engage the child or young person on their own, but also be prepared to involve the parent or carer or third-party people who can give information, so that there is opportunity to gather information, but it's useful to let the child know that you're doing that, so that you can still maintain your relationship of trust. And it is useful to have an allied health staff member to sort of, or a professional to sort of gather the history and contact the various services involved, such as schools and NGOs and other services that may be involved in looking after the needs of the young person, so that the most comprehensive assessment that is possible is able to be achieved. The standard components of a comprehensive assessment of conduct disorders will include trying to get a history of patterns of hostile, defiant, negativistic behaviors very early on in childhood, a history of overt and covert aggression, and theft, property destruction, serious rule violations in children over the age of 11 years. But along with that, so this is the direct information about the sort of aggression and the conduct history, but also there can be a lot of value in understanding the current functioning at home, school, or secondary, college, the relationship with peers, the parenting quality, the history of relationships with the parents. We know that either overly permissive parenting or overly controlling parenting can result in conduct disorder behaviors. Learning difficulties or disabilities, neurodevelopmental conditions like ADHD and autism, neurological disorders like epilepsy and motor impairments, all these things, substance use, communication disorders, and then the frank mental health problems like depression, post-traumatic stress disorder, and bipolar disorder have all been related to aggression. It's quite important to understand the actual risks faced by the child or young person. So even like many aggressive children actually face significant amount of physical and emotional risk from people around them, from peers, from family members. And it's really important to develop a risk management plan for self-neglect, exploitation by others, self-harm or harm to others. So I think it's really, really important to kind of go beyond the history of aggression and violence and see these children certainly in a state of turmoil. A lot of people say that self-harm and aggression, or suicidal behavior and aggression, are two sides of a coin. And so it's really important to kind of assess for suicidal risk as well, and risk of vulnerabilities, risk of sexual or physical vulnerability. But also some of these children might demonstrate some of the behaviors that they have experienced. So they may use sexual violence towards other people, or physical violence or emotional abuse towards other people. But through that process, one can also understand whether they have suffered these problems themselves. An assessment of a comprehensive assessment of the child or the young person will also cover positive and negative aspects of the parenting process of the parents, and it's probably useful at this point to try to understand the experience of the parents of being parented by their parents. So what has been their parenting experience, and how has that influenced the way they have parented the child? Also, other adult relationships, positive and negative other relationships that the child has had with other adults, parental well-being, including mental health, substance use, and criminal behavior in the parents. It's quite important. There's a history of depression, a history of substance misuse, a history of criminal behavior in one of the parents or both parents is significantly associated with criminal behavior and aggression in the child. When we do assessments these days, we have stopped using rating scales and saying, it's high, moderate, low, because we don't believe that those rating scales are particularly useful. They are not reliable and valid. And we also know that people have different ways of assessing risk. So two people's assessments will not be the same based on where they work, their levels of experience, what resources are available to them, and so on and so forth. So we've moved away from that and moved into the realm of preventative risk formulations. So risk formulation is a method by which we understand the factors that drive the aggression or aggression risk in children and young people. And we describe them, and we also talk about what mitigating factors there might be, strengths and other positive factors there might be in helping to mitigate the risk. So within that, there is something called risk status factors. So these are the static factors that are in the history that are unable to be changed. These are factors that increase the likelihood that this young person is more likely to be aggressive than others. They do not necessarily immediately indicate that there is a high risk of aggression, but it points to the likelihood of a history of aggression. These things will include a past history of general offenses, substance use, violence when intoxicated, history of violence when not intoxicated, mental illness symptoms of psychosis, depression, ADHD, anxiety, oppositional and conduct disorder, preoccupation with violent images and video games, and exposure to antisocial peers, to family violence. And we also know that low IQ and learning difficulties are also associated with aggressive behaviors. Then are the factors that are likely to be changed through interventions. So these are the dynamic factors, and they're called the risk state factors. So they are the ones that indicate whether the young person is more likely to be aggressive now than at any other time in their own history. So the risk status factors compares the person's risk to the larger, wider population, or say compared to other patients that you see in your clinic and things like that. Whereas the risk state factors indicate the risk of aggression in the person compared to their own history in the past. And that is across 4 time periods: the last 48 to 24 hours, 48 hours, 1 week, 2 weeks, 2 months, or longer than 2 months. Whether they are likely to be at the same level of risk or higher or lower. So that's sort of the way we compare. So some of the factors we look in there are ongoing symptoms of an underlying mental illness, like second-person command auditory hallucinations, urging the person to harm others, paranoid persecutory delusions, withdrawing from substances, remaining angry, and all of that sort of stuff. Then there are warning signs of impending aggression. So the overt behavior of the young person, like huffing, puffing, pacing up and down, facial indicators like staring, frowning, rubbing forehead, reddening complexion, raised voice, aggressive body language, words expressing threats, including swearing, being argumentative, belligerent, not following instructions. And they can all be kind of classed together with this acronym called STAMP, which is staring, tone of the language, the voice, anxiety, muttering or talking under their breath, and pacing, walking around in a confined space. There are obviously protective factors in everyone. And most of these children have lots of protective factors, which is quite an important thing to focus on. It's one way of actually establishing rapport and making them feel that we are not being, because these children are often used to people being quite punitive towards them. So I think this is kind of very useful to sort of get away from that sort of position and try to focus as much as possible on a balance between looking for risk factors and also the positives. So some of the individual positive factors or protective factors would be, generally girls are, kind of less likely to engage in conduct behavior compared to boys. High IQ, intolerance towards their own sort of sense of intolerance towards deviant behaviors. Positive peer relationships, pro-social peer relationships, and warm supporting parents, an absence of violence in the family, close relationship with the parents and other significant adults, If they have psychosis, then good response to medication, improvement in arousal regulation in a child with neurodevelopmental disorder, whether that is through the use of medication or cognitive behavior therapy. All those factors are positive factors. Developing a care plan is quite important with the young person, their parents, the carers, and which includes a list of the profile of their needs, the risks to self and risks to other people, and it should sort of include things like social and occupational and housing and education needs, the needs of the parents, the strengths of the child and the young person that are, supposed to be harnessed. We have to list the sort of physical health problems that have to be addressed. One of the important things that is often missed in these young people is speech, language, and communication difficulties. So that would be really useful to understand, because that can also be related to learning problems in school, and a referral to a speech pathologist to kind of assess that would be very useful. When discussing treatment or care interventions, it would be really useful to kind of discuss past experience with treatments, how their relationship with past therapists or psychologists has been, what sort of people that they've engaged with better, what sort of people they've not engaged with better, what has been their response going and receiving the therapy, and what has been the impact of the problems on their educational performance, chronic health issues, social family factors, and all those things, and any other sort of coexisting conditions like mental health problems. They all need to be addressed as well. It's very important to try to understand the preference of the child or young person, and also their parents and carers when making referrals. Because one of the things with this group of young people in particular is they should want to change, they should want to work on their issues, and they should want to make a difference for themselves. So it's going to be really important to keep them on board with this process. Otherwise, the treatment is not likely to work. So that would be really important to find out what their preferences are. The DSM-5 has this entity of disruptive mood dysregulation disorder. Some of you may have heard of the term pediatric bipolar disorder. There were a group of people who championed that label. They thought that bipolar disorder develops very early on in life. But DSM-5 did not agree with that, but they did acknowledge that there are a group of young people who engage in violent, aggressive behavior and conduct disorder behavior, but who may actually have an underlying mood disorder. And this is the entity that then came into the DSM-5. So it's the disruptive mood dysregulation disorder that is manifest with severe temper outbursts at least 3 times a week. The mood in between the outbursts is sad, irritable, or angry. So they're angry, irritable all the time with outbursts at least 3 times a week. The reaction of their mood is much worse than what can be expected for the trigger. The minimum age of the child should be 6 years old, but mostly the symptoms begin before the age of 10. So it's an early childhood disorder kind of problem. Symptoms must be present for at least a year, and it must impact not just in one environment, but in multiple environments like home, school, and with friends. This is a look at the treatments. So if you look at the child or the young person has been diagnosed with the risk of developing a conduct disorder, mind you that includes young people who may have a neurodevelopmental disorder like ASD and ADHD. It might include people with depression or bipolar disorder or a predilection for bipolar disorder. There's a family history of bipolar disorder. I saw a young person today who's got a very strong family loading of bipolar disorder in one side of his family, and he presents with ADHD and lots of conduct sort of behavior. And if you kind of take a careful history, these young people often report lots of mood dysregulation, so quick anger and aggression. So the conduct disorder is a kind of behavioral label, but underneath that could be children or young people with lots of different problems. So what we do is necessarily kind of try psychosocial interventions and pharmacological interventions together. So some in the early childhood, obviously, the focus will be more on psychosocial interventions like child focus programs, parent and child dyadic therapy, which is attachment building and enhancing. But also there can be formal training programs for parents and guardians that some services provide. And in the 11 to 17 years, it really requires what's called multimodal intervention. So you have a sort of case manager or a caseworker who actually works with the family, works with school, works with other agencies, brings them all together. And there is a management plan that is developed by everyone together, with the parents and the young person playing a part in that. And everyone works together to kind of support the young person. With the pharmacological interventions, there's not that much impact of medications on the pure oppositional defiant disorder and conduct disorder. But ADHD is obviously treatable using stimulants and other medications, and that's very useful in reducing the impulsiveness. And pharmacological interventions have also been useful in managing aggressive behavior and irritability. I think that there are lots of different medications like risperidone. Some of the newer antipsychotics like aripiprazole and lorazepam have also been shown to be quite helpful. So if you look at kind of the list of medications, you'll find amongst the antipsychotics, some people still use the older ones like haloperidol, but otherwise risperidone, olanzapine, quetiapine. Olanzapine and quetiapine are mood-regulating type antipsychotics, and aripiprazole is more of an antidepressant sort of effect. The stimulants, there are SSRIs and SNRIs like atomoxetine, reboxetine, but other ones as well. Mood stabilizers like lithium sometimes is helpful, and sodium valproate is helpful as well. So if you look at the kind of evidence base for all of them, that you find that the most evidence base probably for pure aggression is with risperidone and stimulant medications for ADHD. Lithium has been found to be helpful in boys with impulsive aggression as well, that are not responsive to risperidone and stimulants. So with risperidone, that's commonly used in young people with violent aggressive behaviors, also if they have ASD as well. It's useful for short-term management. Some people say you try it for a few weeks. If it does not work, then stop it. But some other studies indicate that it's useful to continue that for several months. But the important thing is to manage the metabolic problems. The extrapyramidal problems, the QT interval problems, they're not that significant. With risperidone, it has a lower risk of QT prolongation unless it's combined with other medications that increase QT. But the problem of weight gain and secondary diabetes, an increase in plasma prolactin, resulting in galactorrhea and gynecomastia in boys and galactorrhea in girls is a problem, and they are very unpleasant side effects and experiences. So there are things that we can do to reduce that, which we can talk about in the discussion. Again, there are a lot of people who suggest that we should be doing routine measurements of weight and height and waist and hip measurements, pulse and blood pressure, fasting glucose, HbA1c, blood lipid and prolactin levels, and all those things. But some, so the psychiatric literature would say these things are really important, but we know that in clinical practice, it's not easy to get young people to kind of cooperate in doing that. But if possible, I think it's useful to measure them and also check for compliance or adherence with medication, and look for early signs of movement disorders or extrapyramidal symptoms. So if you look at the effect sizes, the best effect sizes are with the risperidone, but typical antipsychotics are also quite useful, like haloperidol. Interestingly, haloperidol is less likely to cause weight gain. It's more likely to cause the extrapyramidal symptoms and tardive dyskinesia. It's less likely to cause weight gain. In developing a behavior plan, there are three things, the 3Ds we talk about: the drivers or the motivators, which is the gains or the benefits for the person in doing what they are, doing. For example, would it involve some level of control, status, self-esteem, or emotional release? Or does that make them become closer to, the victim or to peer groups? Or is it's fueled by justice or revenge? Or are they just simply reacting to emotional arousal and stimulation? So basically what happens is that when they are aroused and there is a dysregulation of the stimulation, then the reacting of that to that with aggression is kind of acts as a positive feedback loop, and that maintains the behaviors. Then what are the disinhibitors? Are there things like psychosis, ADHD, or depression associated with negative and nihilistic sort of attitudes, substance withdrawal, and things like that? And then what are the destabilizers? What are the things that would in an active way? So is there an active psychosis? Do they often become aggressive during periods of intoxication and things like that? So it is important to then have a list of strategies that would manage each of these things. And I find that sensory strategies and techniques are quite useful. We've started to use them, for example, in our adolescent mental health inpatient units. Across the state now all have sensory rooms with some different interventions, including some video guided sort of relaxation sort of things within that room. So the young people will just go into that room and they will be in that space where they will have, lights and things on the ceiling, on the floor, calming kind of music and calming sort of sensory sort of stimulation, which then calms the young person. So we often find we send the young person into that room, they spend 15-20 minutes or half an hour, however long they wish to be, but when they come back there is a definite sort of improvement in them. Thank you.
Thank you so much, Dr. Prakash. All right, let's have a look at some health pathway slides before we go on to our case study. So actually not slides, I'm going to go through some health pathways with you. So just one sec. Yeah. So I was just having a look at health pathways and went through, just searched behavioral problem in children. So, as Dr. Prakash indicated, and we are aware that behavioral problems in children, can mean many different mental health issues. So when you look into it, it kind of takes you through various different conditions. One particular thing that caught my interest, which we didn't really discuss here, was more so because as a GP, we see so many, parents bringing in their preschoolers where childcare or kinder have, expressed concerns regarding their behavior, and you asking for a referral for an ASD or ADHD assessment, sometimes as young as like ADHD assessment and sometimes as young as 3 years old. So I was going through these health pathways to see, just as a GP to learn what sort of history, I should take so that when I'm making a referral to a pediatrician, eventually it has, adequate information to help triage, or whether there are any tools that I can give parents to use. So it has some really, really, good checklists that we can go through, particularly having adequate perinatal developmental history, medical history, and also takes us through some scores. Some really useful tips and strategies that I found were more like which may sound very simple, but just these screen time limitation strategies, because as a parent, I think this is something that I struggle with the most, that how to limit my daughter from using iPad way too much. So if you guys get time, please have a look at health pathways. You can register for it and it's very, very handy to use. So